tell you in a minute or so. Yeah. Hello and welcome to the 5th conversation in the Let's Talk Public Health series hosted by Azim Premji University. And today's topic is Science and Evidence in Public Health Policies, Insights and Lessons from Policy Practice. Public policy is considered a government's response to public problems. There are several theories that have tried to analyze the public policy processes. Some of these include the black box theory, systems theory, rational choice theory, elite theory, and so on. These theories, while well informing us on some aspects of policy, do not necessarily quench our curiosity to know what happens in that policy black box. It would be of great interest and curiosity to all of us to ask this question, therefore, what happens in the policy making process? A greater interest would also be to know the experiences of those who are engaging with policy processes, either making policies or policy or implementation. Still more, besides having science and evidence on one side, what happens when scientists engage with policy with a strong value and ethical orientation, such as people-centered policy, policy with equity, patient-centered care, etc. So we are here today to listen to one of those wonderful stories from the domain of public health. I would now like to welcome Dr. Soumya Swaminathan amidst us to take us through her journey of engaging with these issues that we have briefly outlined here. Dr. Soumya Swaminathan needs no introduction. She is a renowned Indian physician, scientist, and global health leader who has made significant contributions to global health policy. After completing her medical education, Dr. Swaminathan specialized in pediatrics at the All India Institute for Medical Sciences, AIIMS, New Delhi. She continued research in tuberculosis in Chennai as a research fellow at the National Institute for Research in Tuberculosis. Dr. Swaminathan's effective leadership at the NIRT played an influential role in shaping global epidemiological response and strengthened the strategies for the prevention, diagnosis, and treatment of HIV and TB infections, especially amongst the pediatric population. Dr. Swaminathan has held several leadership positions at renowned institutions that include ICMR, Indian Council for Medical Research, and the World Health Organization. At an extremely critical time in recent history, that is during the times of COVID-19 pandemic, she provided leadership at the World Health Organization as the chief scientist, where she contributed to the global community in thinking around public health strategies. She incorporated political, economic, social, and cultural factors into the development of effective, evidence-based policies and guidelines to guide healthcare professionals globally. As a dedicated physician, researcher, and international health leader, her unwavering commitment to science has left a lasting impact on the field of medicine and public health. It has specially enlightened the public health community on the significance of of science and evidence in public health policy making and how it can positively impact the lives of people. So, Dr. Soumya, thank you for being with us and welcome to you. I now hand over the podium to you to share your experiences with us. Over to you, Dr. Swaminathan.
Thank you. Thank you very much, Edward, and thanks for this invitation to speak in this series of talks, which on very interesting topics and also quite challenging as well. So I will be speaking about science and evidence in public health policies, insights and lessons from policy practice. And as you mentioned, Edward, in the introduction, I will, of course, draw on my own experience, first as a researcher, then as somebody who's trying to influence policy at the high level of government, and then, of course, at the international level, at WHO. I was in the thick of things during the COVID pandemic, but even prior to that, got a very good glimpse into how global policy making happens and how things have actually changed, over the last 5 to 10 years or so, and where we still need to go in order to really make it both evidence-based, but also responsive to what the needs are of countries and of communities. So I will, in 4 broad areas, themes, I will be speaking. First, about understanding how public health policy decisions are made. I think many of us often struggle to understand this if you're an academic or a researcher. Then some stories on how evidence does contribute to action and to changes in policy and practice from my own personal experience. Then a little bit about institutional mechanisms and challenges of implementation. So how do you actually build systems so that it's not a random one-off process, but a systematic institutionalized process for evidence-informed policy making? And I'll end with some of the challenges that are facing us today globally and in India, some of the health threats that we are facing, and why we need a learning health system. So how does real world decision making work? Now, clearly, policy making is neither purely linear nor purely evidence driven, contrary to what a researcher might like or an academic might like. Decisions are made, especially large decisions which impact policies which have a financial implication. They are shaped by, firstly, by political priorities, by administrative realities on is something actually going to be feasible and to work in the current circumstances. And of course, always there are competing demands. There are many, many stakeholders who are going to be requesting for certain policies. Then there are constraints that the policymakers or the administrators face. Obviously, there are always budgetary constraints, workforce constraints, there are timelines to be met. Things are usually done, in a rather rapid, fast timeline, and there are trade-offs which often outweigh the technical evidence that one may present before the policymaker. So I think we have to recognize that evidence is only one input amongst several that a policymaker has to use and use that and wait and then make a judgment. These include the feasibility of a particular action, the ethics and the equity aspects of a particular action, the acceptability by the population, and the risks that could be involved. Now, the role of politics cannot be overemphasized because politics often shape when and how policies are adopted. So there is the election cycle, there are leadership priorities, there are mandates and manifestos which are developed before elections. They often respond to the public mood or the demand, media pressure. So public pressure, media pressure, these play a big role in accelerating decisions far more quickly than the technical evidence alone can. Windows, therefore, matter. Policy windows matter. So there are moments when there is a high level of political attention to a particular issue, or there's a transition, and these create openings where long-standing ideas can move much more rapidly onto the agenda. So sometimes one has to be very patient, and you may see 10 years or 15 years later, ideas that you were pushing, they actually go through. Example that I always like is Thailand's 30 baht universal coverage scheme. Now, like most countries in our region, the healthcare system was, of course, at different levels, but the tertiary healthcare always takes up much more of the resources, and it's a sort of a tap that you can never turn off. So in the 2000 election, the RAK Thai party identified healthcare access as a key public concern. But even before that, it was based on long years of experience of public health doctors, or doctors very committed to deliver public health and primary health care in Thailand from the 60s and 70s, actually going and working in primary healthcare centers and also engaging the community and the public quite a bit, creating a demand for services and also trying to provide quality healthcare at that level. And therefore, I think there was a public demand, and the political party in question at that time identified it as a key public concern And we have to give credit to all the Thai doctors, actually, who are all very senior now, but at that time they were all young people and they were pushing for more attention to public health. And so they proposed a simple, highly tangible solution called the 30 baht scheme, like 30 rupees. You pay 30 rupees and you get health coverage for all diseases for the entire year. This slogan generated strong resonance and an electoral momentum. This party actually won, and the new government moved to implement this scheme nationwide. This was a massive reform because what they did also at that time was they put a hold on all new tertiary care hospitals. It's a very bold political decision to stop investing and building new tertiary care hospitals and divert entire health budget to strengthening primary health care. And if you go to Thailand, you will see how beautifully the whole system works, how right from the community level to the first, second, and third levels of care, you have a system that actually delivers very quality health services to the people without overburdening the tertiary care system. So this reform, that is the universal health coverage scheme in Thailand, was driven not only by the evidence, but by public mandate and public demand, by political commitment and the urgency to deliver on a campaign promise. So technical design, the message is, or the learning is, that technical design is essential, but it's not enough. Political will and timing will often determine which policies actually get implemented. Now, there is a gap between science or researchers and policy. We often start with very different goals. A researcher would prioritize rigorous study design and a good outcome, while the policymaker needs timely, workable solutions for the system. So the timelines are also very different. And if you look at it from the policymaker's lens, you will see that every recommendation must be affordable, it should be cost effective, it should be feasible to implement across diverse settings, and it should be a low risk for the system. The research timelines, on the other hand, are generally longer, much longer, but policy decisions often need to be made within weeks or months, creating a natural mismatch. Policymakers need answers to practical questions, which research often does not address. So they don't want to know whether a certain intervention is good or bad, or if it works or doesn't work. They want to know, will it work here? Will it work now? Can we implement it at scale? And what are the risks? And what are the needs to implement something, in a particular context? Now, ethics, equity, and the role of dialogue. Public health decisions affect millions of people, particularly in a country like India. If you make a decision, it impacts literally hundreds of millions of people. So ethical and equity considerations must always guide every policy choice. And generally, political leaders will tend to prioritize this because they are always look at it from the voters' point of view, the public point of view, and how to provide benefits for the maximum number of people. However, the interventions must also be acceptable to communities and avoid causing stigma or unintended harm, especially for vulnerable groups. Now, there are many good examples of how this was done well, but during the pandemic, for example, there were certain things done that actually caused unintended harm to certain groups of society. And that's because it was an emergency. During the pandemic, decisions were made very quickly. There was no time to really analyze or take into consideration many factors or consult a lot of people. But the learning from that is that even in an emergency, the next time around, if there is another epidemic or a pandemic and one has to make decisions, for example, like a lockdown, you should have a group of people who are not just purely technical or administrative, but who have the background of law, of social sciences, of behavioral economics, of ethics, and communities. So you need those representatives to be around the table when very big and far-reaching decisions are made. I mean, that's an ideal situation. So, but if it's not a pandemic, let's say, even then, it requires an early dialogue between researchers, implementers, and affected communities, again, ideally, because the views and the perspectives of these would be a little bit different. And so it's only when you talk, for example, as a researcher, I used to go to the community and I used to come back with perspectives that I would not have considered, So they would challenge me about certain presumptions or assumptions that I have made. Continuous exchange between these groups, such as the researcher, the implementer, and the affected communities, will ensure that evidence responds to real operational concerns and protects equity when it is scaled. For example, if we want to bring a new reform in the primary healthcare, the way we are delivering it, I would go first to the frontline workers, the ASHAs, the NMs, the Anganwadi workers, the mid-level health providers, and I would ask them, what are the challenges they are facing? What is it that works well? What doesn't work well? How can their work be made easier and better? And if you do that, then you immediately come back knowing what the on-the-ground challenges are where you need to act. Otherwise, you could be sitting in a room in the capital of the state and writing out a document which conflicts with what is actually happening in reality. So I find it very, very useful always throughout my career to always go back to the community and say, hey, here's a policy change that is being considered, or this is what the evidence shows. How should it be implemented in order to make it most useful and also delivered easily? Few examples. So way back in the 90s, when HIV was becoming more and more common, and I was working at the Tuberculosis Research Center, as Edward had mentioned in the introduction. And from other parts of the world, like Africa, we knew that TB was the most common infection as immunity declined for people with HIV infection, and that HIV and TB together could become a huge problem, and that most HIV patients who died also would die of TB in a country where TB is very common and where it's endemic. So the idea was, okay, since we know that, should we not be testing all our TB patients for HIV when they get diagnosed or when they come to seek care for TB symptoms? Now, the concern at that time with the policymaker was that the TB program is a well-established program. It's running well. In fact, it was right at that point where it was getting sort of rejuvenated, the renewed or the revised RNTCP, the revised National TB Control Program, had been launched. I think it was 91. And there was concern that bringing in something new like HIV testing, which had a lot of stigma around it at that time, as you know, there was no treatment, and people might run away, people might not even seek TB care, and the whole TB program would collapse. So we undertook an operational research study in a couple of districts in India to assess the acceptability and the operational fit. And the findings immediately showed a strong acceptance among patients and providers, and there really was no downside to offering this testing. Of course, if you did it with counseling. So it was HIV, always testing is preceded by counseling. And the result was that within a year or so, routine HIV testing was integrated into the National TB program. So here, what happened was that research directly answered the policymakers' concerns, and it showed how evidence could resolve uncertainty and accelerate adoption. So another example, also when I was in the ICMR, was that we came across a paper, some evidence that giving 3 drugs for the prevention of lymphatic filariasis was actually better than giving 2 drugs, which was a standard practice at that time. So there was a clinical trial that had been done showing a higher efficacy of a triple drug therapy. Now, the policymakers said, look, people already don't accept this mass preventive therapy because you're giving healthy population drugs and some of them get some side effects. Now, if you're going to add a 3rd drug and you get more side effects, then this is going to kill the mass administration program. So the ICMR conducted field demonstration studies in 2 districts in Karnataka, where we actually went out, and everyone from the collector down was actually involved in this. It was a massive awareness building. There was nurses in every village that actually told people that you don't have to be scared. We are there. You can come to us if you have side effects, because some people get fever when you give them this, if they already have filarial antigenemia, then when you give this triple drug, then a lot of the filaria get killed. They get and there's a response, and you sometimes can develop fever and shivering and so on. So the result of this study actually showed that the safety profile was completely acceptable, and it also showed that community awareness, creating that knowledge, informing all government officers from the collector down, but also involving people, reassuring them that symptomatic treatment will be provided if they get symptoms after administration of this drug. So make sure that paracetamol is available in the village. There was a nurse who stayed there overnight. The result outcome was the National Vector-Borne Disease Control Program adopted this triple drug therapy. Again, this was done in a very short period of time, and the research was not answering that does it work, because that the randomized trial had already done, but will it work safely here? And so this is a question that often matters most for policymakers. Another example, hypertension. As you know, NCD burden in India is growing, has been growing for a while. There's been an epidemiological transition, which has gone kind of very silently, happened over the last few decades. Suddenly we find ourselves with a huge burden of hypertension and diabetes. Now we know, for example, from the National TB Control Program, that a standardized approach, when you have a public health program, you need a standardized approach. You need SOPs for diagnosis, for treatment, for referral, for management, protocols. You need supply chains. You need a reporting system. You need a monitoring system. Now, TB program was doing this for the last 50 years. So we said, why not we do this for hypertension? So the ICMR took 5 districts and piloted the India Hypertension Control Initiative, which had 5 main components: standardized treatment protocols, very simple, 1 or 2 drugs, a reliable drug supply, because that used to be a big problem before this program started, because hypertension treatment was just not a part of primary health care at that point. Fast sharing, so there are 3 or 4 people in a PHC, who's going to do what? Now, of course, we have NCD nurses. At that time, the nurse had to be trained, patient-centered services, and data monitoring. A very simple app was created, so the nurses could actually record the patient details. Follow-up became very easy. There were digital alerts, and she could track all the hypertension patients that she had in her center. Now, once this demonstration happened, in the first year or so, the model was expanded to 25 districts, and then very rapidly expanded by the ministry to 100 districts. And now, of course, this program covers the entire country. Similarly, the Methanion program in Chhattisgarh, the problem there was that it's a very large rural and tribal communities, far-flung, health system was not that well developed, transport problems. So they lacked regular access to frontline care and had very weak links to public health services. In 2002, the government of Chhattisgarh and the State Health Resource Center introduced the Methanion program, where these women actually were selected by the community. They were from the community. They were trained to deliver basic care, nutrition support, behavior change, communication, and to act as a link between households and the health system. The initial rollout was in a few blocks, and based on the positive early results, the program was expanded phase-wise. Today, there are about 72,000 Methanions in Chhattisgarh, covering almost every hamlet, and a lot of independent evaluations report very strong coverage and community trust and buy-in. The program is recognized as one of India's most successful community health worker models, and it informed the design of ASHAs nationally. And as you know, now India has over 1 million ASHAs, and the WHO did recognize ASHAs with their global health prize, actually, 2 years ago. Now coming to the third aspect, which is how do you build systems for evidence-informed policy making? Now, if you rely on individuals for policy making, then or decision making, it is going to vary widely. And one individual comes and goes, things will not sustain. So it's only when systems exist with structured pathways for appraisal and decision making that governments can actually use that system to compare options using standardized criteria like cost effectiveness, affordability, feasibility, equity, system capacity, and so on. So if you don't use these mechanisms, then evidence use becomes inconsistent and it becomes dependent on personal networks and vulnerable to political cycles. So countries would have strong institutional processes like health technology assessment bodies, national research units like the NIHR in the UK, NICE in the UK, demonstrate much better long-term policy continuity and accountability. So otherwise, if evidence use is not embedded into the system, then it collapses the moment key people move on. So again, my own experience from HTA in India in the year 2015, 2016, we established this unit under the Department of Health Research to support evidence-informed priority setting, but also conduct economic evaluations to inform the adoption, the pricing, and the reimbursement of health technologies. So it's grown a lot in the last 9 or 10 years. Now there are 19 state cells and 8 resource hubs, many more resource centers and technical partners. And the number of HTA studies, keeps increasing. I think it's 98 completed ones at last count. But very importantly, this has supported national level deliberations and policies, including on the design of the PMJY benefit packages and cost-effective interventions, and is now being used to evaluate new diagnostic and treatment technologies. As you know, there's a lot of new technologies now that are coming in. So this becomes very important to say, is this more cost-effective than what we're already doing? And how many more DALIs is it going to save? And so on. So then it becomes much easier to convince a policymaker to actually adopt a new technology. And now what is being done is to strengthen these cells, the HTA cells in states, because one HTA unit in the center cannot serve the whole country. Every state has their own priorities and needs. But this is a very well-established sort of a mechanism or a procedure to use actually to when you want to assess a new technology that's coming in, whether it's a diagnostic or whether it's a treatment or a preventive. For example, if someone wants to bring in a new vaccine into the national immunization program, first, of course, you'd look at the burden of disease, you'd look at efficacy and all of the studies to ensure that efficacy and safety have been well established. But the next step would be to put it through the health technology assessment, and it would tell you whether that vaccine would be very cost effective or moderately cost effective or not cost effective for India. And there's a very good methodology behind that. Now, of course, evidence alone does not guarantee results. Just because something has worked in a clinical trial or a control setting doesn't mean that it's going to work when it's implemented. This is why we need to continuously monitor and see whether policies are working as intended. And again, an example from the TB control program, for many years, there used to be an external evaluation every 5 years or so. You bring in experts from around the world. They come, they spend 10 days or 2 weeks in India, going around, reviewing performance, challenges, gaps, talking to staff, talking to people, patients. And these reports and the feedback that was given to the government allowed the TB program to learn, adapt, and course correct. And this is a practice that should be used more. It's missing in many areas of primary health care, where such systematic review of the program is rare. Very recently, the Karnataka government evaluated several of their guarantee schemes that were started about 2.5 years ago. And it was a very useful exercise. It was done by academics independently, third-party assessments, but showed where things worked well, where the impact was, and where there could be still gaps, which should be addressed by modifying that policy by adding certain things to it. So obviously, if you want to be a learning system, then you need to have these kind of methodologies. Now, why do we need a learning health system? Well, many reasons. One, of course, is that the burden of disease has shifted. If you look at where we were in 2000 and where we are in 2023, this is from the global burden of disease, looking at both DALYs, but also looking at the percentage of total deaths. You can see that in 2000, we had maternal and neonatal diseases, respiratory infections, including TB, enteric infections, and so on, in the top 5 causes of DALYs, whereas now we have cardiovascular disease as number 1, also neoplasms and chronic respiratory disease in the top 5. Of course, you still have the maternal, neonatal, and infections, including TB. Similarly, if you look at percentage of total deaths, you can see the shift. Just from the colors, you can see that the blue has gone up in the top 5, which means that the chronic or non-communicable diseases today are the major cause of morbidity and mortality. So that's one reason that the disease burden is changing. The other is that global threats are also rapidly escalating and becoming intertwined. So you can see that, you have the threats which are in green, which are related to things like climate change and pollution and biodiversity loss. And then you have other threats which are occurring, like in the purple, you'll see that, the cybersecurity and the AI and the deep fakes and those cries. There are social tensions which are increasing. There are, of course, the threats of, infectious diseases and pandemics and so on. So, and then there are the economic threats, of course, the post-COVID, there was a big economic downturn. Now there are all sorts of trade issues between countries that are, and of course, there's now the withdrawal of particularly US aid to many developing countries for that used to support programs for HIV, TB, malaria, and so on, immunization programs. So there are a lot of threats and a lot of things which are happening globally, that some of them will get worse in the years to come. Another big one, of course, is climate change. And this graphic sort of shows you how the ecological determinants of health, which are things like, water and sea level rise and heating and the green infrastructure, changes there, changes in the soil, then impacts the social and structural determinants of health. These in turn impact health systems, because obviously health systems exist within society, within the community, and these result in health impacts, whether it's heat-related illnesses, whether it's mental health, if you've been affected by a flood and you've had to move out of your home, there's trauma, there's PTSD, there's more now chronic diseases going up because of things like air pollution. And of course, vector-borne diseases like dengue and malaria, they are also spreading into areas where they did not exist before, because a vector is able to survive. Malnutrition, because there's more drought, and the nutrition content of crops has been declining. And conflict and migration as a result of climate change. You have climate refugees and so on. So this is massive. It's there in all countries, but every country has their own sort of climatic, risks and hazards, which could be unique. India is a very climate vulnerable country. We have not only extreme heat that's increasing, but we also have the frequency and the nature of floods, landslides, cyclonic storms, and so on. And it's if you look at the Met records, every day of 2025 and 85% of the days in 2024, there was one natural disaster occurring in some part of the country or the other. Look at air pollution. It's, of course, in the headlines today because Delhi and the area region of the Indo-Gangetic Plain is in the winter months suffers very, very badly. I mean, the AQI is just, really it's a public health emergency. To put it very, very bluntly, it's a public health emergency. We know from WHO and WMO that 7 to 8 million premature deaths around the world. In India alone, 2 million premature deaths due to more heart disease, lung disease, stroke, lung cancer, and so on. It affects babies, particularly young children. It affects their brain development. So it affects cognition and school performance. household air pollution still accounts for a loss of a large number of healthy lives, and particularly an impact on women in low and middle income countries, because they are the ones who are cooking using biomass. 2 billion people still lack access to clean fuels. That's the estimate by 2030. But very little funding is actually going to cleaning up our air. When you combine heat and air pollution, like in many parts of the world and many parts of India, the risk of excess death, which occurs when there is both high temperature and air pollution, is much more than when there is either alone. So this is even more worrying, because we should not think that the air pollution problem is a problem of Delhi alone. No, there's hardly any part of India that meets the WHO norms of PM 2.5 or 5 micrograms per meter cube. It's way above that, sometimes 8, 10, 20 times above that limit. And so every millimeter you go above, or every microgram of PM 2.5 you go above this limit, is harmful for our health and is taking away years of life. We've done some work at MSSRF on heat impacts, particularly looking at the impact on women and children. We first did a scoping review in 2024. And after that, we did a survey this year of about 3,500 women across 7 states. And basically, women are reporting exhaustion, dehydration, sleep disturbance, headache, and fatigue during the most hottest parts of the year, but also a lot of reproductive health issues, urinary infections, pregnancy stress, emotional strain. Climate shocks are compounded, of course, by already being vulnerable, by living with poor housing or water scarcity and livelihood instability. So it is going to affect the people who are already marginalized much more. We need much more gender sensitive climate and heat action plans. We need health departments to be much more prepared, more resilient to meet the climate shocks which are going to happen more and more, whether it's heat or whether it's floods. And we need data systems that will identify these vulnerable groups and target the interventions effectively. Another big threat, of course, is pandemic threats. We know that the WHO has been warning that every country needs to step up its preparedness, because it's a matter of not if, but when the next pandemic will emerge. We know that there's all kinds of avian influenza strains, for example, that are circulating now in different species. We, of course, also have coronaviruses, Nipah virus, and even drug-resistant bacteria. Antimicrobial resistance also is a pandemic threat, though it's a more slow-moving one. So I was part of the group that prepared this report for the Niti Aayog, which also recognized that the first 100 days of an outbreak are very critical. And there are currently gaps that prevent us from responding fully in the first 100 days. That means you have to be able to be prepared to quickly develop diagnostics, vaccines, drugs, whatever you need for public health interventions to deal with the new outbreak. And it has to, if you do it in the first 100 days, you can save, many more lives. So we need real-time data. Right now, the surveillance systems and information systems are slow. They are not in real time. The state capacity is uneven. But there will be a high social and economic cost from delayed action. So there are many recommendations, and you can see the report. It's available on the website, but essentially we've talked about the need, for better structured governance for pandemic preparedness and response, with financial allocations, with responsibilities given to people, revamping the Epidemic Prevention Act of 1897. We don't have a modern act that governs epidemics, outbreaks, and pandemics, focusing on data. How and will the data be actually, from all these siloed data sets we have, how will we bring them together? The animal data. So of course, now there's a national One Health mission. And one of the aims is to integrate environmental, animal, veterinary, wildlife, human data so that we can sort of monitor the threats and where they're emerging from and so on. And then the 100-day response. So as soon as there is an outbreak, a signal, what do you do? And there's a lot of R&D, preparatory R&D that needs to be done with both in the public and the private sector working together so that you can actually develop the sort of tests and vaccines or drugs that you need very quickly. And that cannot be done unless there's preparatory things which have been done well in advance. So investment into these systems is going to be very important. So I think a learning health system is also one where you have data and feedback and evaluation so that the policy cycles interconnected, where learning keeps happening at all levels of the system, right from the front line all the way up, to the most senior bureaucrat. We still rely a lot on periodic surveys like the National Family Health Survey because we're still not at the point where we can track in real time. So ideally, we need good vital statistics. So you need your birth and your death registration. We still have 2/3 of rural deaths which are not really certified, slightly better in urban areas, but even there, the cause of death is not well documented. So unless you have that, you will never know about your disease burden in a particular place, and therefore your policy action is also limited by that. Again, at the district level, if you had good morbidity and mortality data, you could identify emerging problems, you could see where you're doing well, where you're not doing well, and plan services proactively. So whether it's a nutrition program or an NCD program or a TB program, you need this to enable timely and decentralized decision making, so that you can do this sort of corrective action on a regular basis based on the data and not wait years and years for corrective action. And finally, we have technology that's really emerging to address some of the gaps. While timely, high quality data is foundational, cannot be replaced. But innovations, particularly in India in the last few years, we've seen that they are really making a difference in enabling things to be done much more efficiently, affordably, and quickly, where in the past it was not possible. So a few examples. The Bempu bracelet was developed as, this was many years ago, as a low-cost wearable hypothermia alert bracelet, so that when you discharge a small baby, a premature baby or a baby that's born small for gestational age, you allow it to go home with the bracelet on, because hypothermia, that's low temperature, is a killer in babies. It could be due to many reasons, but quite often it's due to infection or sepsis. And this thing would go off, an alert will happen. Mother can immediately, or the relative can immediately pick up the baby, warm the baby, and if the hypothermia persists for a few hours or more, then obviously seek medical care because you know that something is wrong. Similarly, we have an app called Swasa, supported by the Anjani Mashelkar Foundation. This is a software as a medical device. So basically, you cough into this, the app is on your phone, and it will screen you for respiratory problems through analysis of cough sounds using an AI-driven cough sound analysis. So whether it's COVID or is it TB or is it COPD or something else, this app is trying to make you, just through analyzing your cough sounds, be able to sort of distinguish and say, well, this sounds more like a TB cough, so you should go and get the other test done. It's a very affordable and low cost kind of an innovation. It has been validated, and now I think at the state level, it's kind of getting picked up in one or two places. So this kind of platform exemplifies disruptive technologies. Normally, this person would have to go get the auscultation done by a doctor, then get an X-ray, go somewhere else to get a sputum test or further investigations. This could actually help by triaging right there at the doorstep and giving an opportunity to improve access and equity. So again, continuous real-time use of evidence, as I mentioned, is very important. And ultimately, that's what we want our health system to look like. If it's a really good learning health system, we collect data on disease burden, but also on service quality, on health outcomes, and feed that back into, where the weaknesses, gaps could be. So again, what could be an institutional mechanism? A state health systems resource center working with the academics, with the universities, with the medical colleges in the region could actually do this quite well, and have then periodic multi-stakeholder assessments like the TB joint external evaluation that I mentioned, or have a mechanism for a continuous feedback, like a people's health assembly at the district level, at the state level, so that you're also getting feedback from the community. Like Thailand does that very well. They do their regular health assemblies where the people actually come and say, how well the healthcare delivery is taking place or not taking place. Similarly, having a platform where policymakers, field level staff, researchers, civil society organizations, community representatives, if they can routinely engage, for example, again, it could be through a health assembly, it could be, some much more local decentralized thing at the panchayat level, then, you ensure that the evidence is demand driven and it's grounded in lived realities. Robust regulatory mechanisms are very important. I really want to emphasize that, whether it's a drug regulatory mechanism or whether it's environmental health regulation. For example, air pollution, we talked about, is one of the biggest risk factors for health today. It's diet and air pollution are the two biggest risk factors for health in India, driving a lot of our disease burden. But no single body currently is driving coordinated action. Responsibilities are diffused, and therefore nobody is really accountable. Things are not moving in the right direction. Similarly, for sugar consumption, which is linked, of course, clearly to obesity and diabetes and so on, we need our food safety regulator to become, much stronger in implementation of front of pack labeling and ensuring that the companies are not making claims which are not backed by any evidence. And again, from Thailand, I really like their model where they use what they call the sin taxes on tobacco, alcohol, and so on, putting it into this health promotion foundation, which looks at policies holistically across health promotion, prevention, and regulation, not just curative services. So I think to wrap up, I would say that recognizing policy-making realities and fostering collaboration between all these different stakeholders, which take into account real-world constraints like budgets, feasibility, timelines, ethics, having a dialogue will ensure relevance and uptake of good policies. Institutionalizing the evidence process through mechanisms like the health technology assessment with state health technology assessment cells, state health resource system, SHRCs, and routine external program evaluations, and having structured channels for translating research into policy, strengthening regulatory mechanisms, both at the central and the state level, investing in data systems, particularly real-time data systems, but also strengthening our vital statistics. It's high time that we had a much better cause of death reporting. It's been a very long time. I think all doctors need to be trained on how to report this, and it can be done, digitally and electronically. And for people who die at home in rural areas, we could have a short questionnaire, which is like a verbal autopsy, which will try and determine, the most reasonable cause of death. And then, of course, we need the commitment that we will use research and evidence and data to and include civil society in trying to improve our healthcare deliveries all the time. So I think that with that, I will probably have concluded my presentation, but I'm very happy to open it up to discussion and take comments and questions. Thank you.
Thank you, very much, Dr. Soumya, for taking us through a long, I'm saying, very process of which covers the entire policy cycle, across to the globe and in a local level, also national and international level. You began with rightly the politics, which where the evidence is located, and you have led us to understanding how important systems are and learning systems. You have emphasized quite a bit on why learning systems are important through a lot of examples. You also told us in between about the whole issue of how evidence works, whether it works here and now, which is important for a policymaker. You've also given us various avenues where this evidence needs to be streamlined, convergence has to happen, and quite a lot of action has to be syncretic or synchronized action has to be there, along with various recommendations that you have highlighted for regulatory mechanisms, collaborations, institutionalizing evidence, and also for strengthening systems. And overall, you also said that investment of different kinds is required in all these areas. Thank you so much for highlighting these and also bringing it up through your own personal examples and engagement. I would like to pose one or two questions initially to initiate the discussion, which is coming from your own, from your own experiences. While we have certain other questions from the participants, and we will compile them and also present it to you. The first question that I have is, Dr. Swaminathan, much of your work that you presented in TB, in HIV, in other places, there was a kind of a first piloting. You really chose certain districts or locations or geographies, and you really tested. And what comes across is there is this evidence of equity, then the people centeredness, that you should reach everybody. All those thoughts are behind that. When you scale it up at the national level, for example, from 5 districts to 500 districts, what do you think are the challenges? Is it happening in its complete form that you would have envisaged, or you thought there are certain challenges that came in between while scaling it up as a policy at the national level? Or what are the challenges to have it done? Because as a scientist, you would say this is a must. It can't be compromised. So from the question is around scaling up. Generally, we think about scale up, which is already a national level policy. What are your experiences of what gets lost, what gets implemented? What is there in between, the compromises that you make? Maybe if you can share some glimpses of your own engagement, it will be very great for us to listen to you.
Yeah, no, that's a good point. And I think that's what actually our policymakers are good at. So a researcher may not be able to actually give you all the things that are needed, but certainly, the people who've been running our systems, they know what is to be done. But in a brief nutshell, I think what you need is you need standardization, because otherwise it's not going to work at scale. So in a small research study, you can have flexibility, you can do things because it's a small group of people and you're communicating with them. But here you need SOPs for everything. So those have to be definitely made. You need a training program and a training modules, because this is going to be rolled out across the country. You're going to have to train thousands of healthcare workers in a standardized way. You need a supply chain and logistics to be worked out. If it involves certain drugs and diagnostics, you can't roll out a national program without knowing that there is going to be a uninterrupted supply of drugs and diagnostics. You need to know how you're going to capture the data. So you'll need to set up those data platforms. Nowadays, of course, most of it is being done digitally. Earlier, it was done by hand and on paper and then transcribed. And you'll have to have a technical team that is actually looking at the data and monitoring and providing corrective action, and also keeping up with the evidence base. Because as your new randomized trials are done, as for example in TB, we didn't have good treatment for multi-drug resistant TB for many years. We had very poor outcomes. Then a few years ago, a couple of trials showed amazing results with a combination of new drugs, which really improved cure rates to over 90%, which had never been done before. So immediately you will need to change to that regimen. You can't continue to use old regimen and give people bad outcomes. So there's got to be that science also coming into your program all the time. But I think the other elements I mentioned are very, very critical.
Yeah, thank you for that. I think these are all very good insights that we get from you. I see in you a person who has straddled between two worlds. One is of evidence, research, science, and medicine, and also the world of policy, making and implementing. Uh, so it's not quite often that these meet successfully. So you had this unique privilege, and quite often we hear from the other side who are not engaged with the policy making, but we critique and we read that it could be a very frustrating kind of a process, and sometimes what you desire, what you want to happen doesn't happen for various reasons. In your case, you have moved from a state to national to international level. Are there examples where you could manage the meeting of both, in a way that could form into a policy, and you had certain amount of satisfaction in pushing evidence through politics and making it a policy? Are there some, from your own examples? Do you think it was a very? How did you balance this? Is a question.
Yeah. At the national level, I think I gave a few examples where I was personally involved, either as director of the National Research TB Institute or as DG ICMR. The global level also, there were things that we did at the WHO which enhanced the uptake of policy. For example, one was including civil society voices in the TB guideline process. So there's a very stringent guideline development process, which is very evidence-based and so on. But I think the feedback from the community was that there are no people with lived experience in that committee. So we quickly added people who had lived with and survived and been treated for MDR TB, because they have actually experienced what that treatment feels like, and they could give their insights. Similarly, when we talk about non-communicable diseases, traditionally there were only 4 risk factors like physical inactivity, tobacco, alcohol, and the fourth one diet for a non-communicable disease. But we recognize that pollution, air pollution, is a very important risk factor, and added that as a 5th risk factor. So from 4 by 4, the target at the global level where the leaders meet in the UN General Assembly, for them it's important to recognize. So when they commit to something there at the UN General Assembly, that means that when they go back to their countries, they are supposed to act on that, and they are supposed to allocate resources and find and develop policies to work on, in this case, non-communicable diseases. So it's very important sometimes at the global level to, even if it's a matter of adding a few words to a document before it is finally accepted by the leaders, whether it's health ministers at the World Health Assembly or whether it's the heads of state at the UN General Assembly. Once in a while, health documents go to the UN General Assembly also. And there, of course, it's debated, and countries, that's where the politics comes in, ideologies come in. Some countries want you to remove one set of language or put some other language. So there is a lot of diplomacy involved as well. But from my perspective, it was always like, let's stick to the science, let's stick to the evidence. We should not be driven by ideology. So for WHO or any global agency that's a normative agency, you have to be science-based. You cannot actually get influenced by politics of one country or another, or the ideology of one country. So during COVID, one more good example was we recognized that the evidence was very fast in getting created. So it's not like any normal disease or health condition. Within days and weeks, you're getting new clinical trials, new data. You cannot do policy making in the usual way. So we created something called the living guidelines, which meant that every time a new clinical trial was published or data was available, we would do an update of the living systematic review, and the guidance would change appropriately. So our guidelines were changing every 2 weeks or so. Every time a new clinical trial came out, yes, this drug gives a benefit, does not give a benefit. So that doctors, countries, individuals are not wasting money on treatments which are not effective for COVID. As you know, there were more trials showing not effective compared to effective. Very few drugs turned out to be effective, like dexamethasone. So it was important for WHO to keep on updating. Same for vaccines also. People were worried about side effects. We need to keep updating our guidelines. So the living guideline approach, I think, is a wonderful innovation which happened during COVID, which we should use. We should use much more.
Thank you. Thank you. There are several questions from the participants, but I would like to pose my last one from my side. From your recent column in the Hindu that you spoke about the redefining the narrative of TB eradication worldwide, that's about the patient-centeredness, equity, example where your molecular diagnostics, where you said the now lab goes to the people, that is similar to your SWAS and other examples. And you mentioned about this Cohon prize that is given to one of the labs that came to India. So if you can just, because I thought it's a great story where equity, affordability, accessibility, patient-centeredness, patient care, all that comes together. Of course, it was heartening to know that the story of TB is not yet dead, because a long time we thought nothing is happening in the TB. Now your column also reignited some of these ideas. If you can just tell us a bit about that, and then we'll move on. So that will be useful for most of our people who are participating in the session.
Yes. So you're right that in TB for many, many years, we have been stuck for decades and decades with the old ways of diagnosis and the same drug because private sector was not investing at all. TB is a disease of the poor. It's a neglected tropical disease and so on. So there's no big company is going to invest. Now, even this molecular diagnostic, the first one was, by a company, a US multinational company, which had a monopoly for almost 10 years. The diagnostic test was excellent. It gave you the result very quickly, and the whole world started using it because it was so much better than the sputum smear microscopy. But it cost $10, per test, and the machine cost tens of thousands of dollars. So when these innovations started happening in India, the main difference was that with the same level of accuracy, we were able to reduce the price and improve the affordability, and also look at things like the robustness of the machine. The platform should not require air conditioning. It can be used in any primary health center. It should be easy to use by the technician. All that is important. And now we have a lot more innovations. Of course, Small Bio won the Kochon Prize, but we have companies like Huwell who've come out with a tongue swab similar to the rapid test for COVID. We have PCRs now, open source PCRs. We have AI-based X-ray reading, small devices like cameras, which actually are X-ray machines. You can carry them in your backpack and go into the field and do X-rays there, and it'll be read by AI, and within a few minutes, you'll know whether the person should go for further investigations or not. So these are all happening in India, and we are actually leading, I think, on the health innovation side. And the whole global South countries of low and middle income countries actually can benefit from this type of affordable innovation. It has to be high quality. You cannot compromise on quality, but the innovation is in how easy it is to perform and also bringing the cost down.
Okay, so that is a very good, heartening story to, listen to. When at least in the case of TB. I would like now to bring some questions from the participants to your attention, not in any particular order, but as far they have shown a lot of interest. I will read them as they are, and you can respond to them one by one. So one of the questions was that the examples given about policy concern driving evidence collection was enlightening, but how often does it happen that concerns are raised by policymakers for which evidence needs to be collected? Is it usually a concern from policymakers or from people that pushes evidence collection? Is it which comes first, and has it happened as the reverse has happened?
Yeah, obviously the questions coming from policymakers, not the only one, the only reason why you would want to collect data or do more research. It's one of them. But I think unless you have that dialogue and the platform to have that discussion, it's not going to happen. But I would say that it's happening more and more, that policymakers know exactly where their, the spot is where they need more data to bolster up their policies. But we need a systematic way of doing it. Right now, I think it's still not that systematic.
Okay, okay. Thank you, thank you. There's another question which speaks up, highlights the complexity of evidence itself. With the newer challenges which are now more complex, is evidence a greater itself is a greater challenge? I'm saying, what are your experiences around this?
Is what a greater challenge? Sorry.
Is evidence itself, means gathering
Ah,
evidence, framing of
yeah.
evidence, or forcing of evidence to the policy, is it itself is it a great challenge? What do you think?
No, as complexity increases, certainly it becomes more challenging, because there's a particular infectious disease, you're collecting data that's quite different from, let's say, something like climate change or even extreme heat, where there are many different pathways by which it could influence the outcome. And to tease it all out is complex. When it comes to, let's say, behavioral issues, which are often not considered in public health policies, then also it is complex. That's why another point that I always like to iterate is that social and behavioral science must be part of our inquiry, a part of our research. It cannot be a purely biomedical approach, because public health policies essentially depend a lot on behavior, people's behavior, whether it's the consumer or it's the healthcare provider.
Yeah.
So I think bringing those elements in and having a mixed multidisciplinary team designing the research, that actually adds a lot of value, particularly when it comes to these complex areas. You require many people from different disciplines sitting around the table to design and execute the research.
Okay, thank you. Couple of questions are around our recent pandemic experiences, COVID-19, and the other thing. This is our very proximate memory that we have got of how everybody was somewhere or they engaged. So, COVID pandemic needed evidence-informed decision making in a very short span of time. However, this decision making process was faced with challenges of misinformation, disinformation, coupled with vaccine hesitance in some contexts. What lessons do we learn to equip systems to fight such challenges?
Yeah, that's a very good point. So, one is the process of evidence and data collection and how that feeds into guidelines. And I talked about living guidelines. So, you need a
Yeah.
team that's constantly reviewing the literature and feeding the evidence into the guideline process. But I think the how to handle mis and disinformation is another area where it's a new area. I think we did face it during COVID. And there were challenges, and we were learning how to deal with it. It was the first time that we had a pandemic in a social media age, so we did not expect that the social media environment would be throwing up all of these challenges, and that there were groups of people who were actually focusing on disinformation campaigns, particularly against vaccines. This is again a new area which needs actually more work, more research, and ongoing sort of innovation. It is also an area which requires interdisciplinary and multidisciplinary expertise. And I think there is no quick fix, particularly in the today's age of deep fakes and all that. But a few things we can do. One is that every government department, particularly public health departments, will have to invest in this. How to recognize, how to be prepared, how to
Okay.
prevent, and how to respond quickly to any misinformation, disinformation. So be proactive in health communication rather than reactive, because the fellows who are spreading bad news, they are also always going to be spreading it faster than those who are giving. The other is, how do you make health information more user friendly, attractive, use communication methods which people are liking and which they use, rather than the boring standard ways of giving health information. So that's the trick that the misinformation people use, right? They have very attractively done videos and clips and reels and all that. So I think health communication has a long way to go, but ultimately, it's also about trust, and we have to maintain that trust. So if the public starts losing trust in public health authorities or in government officials, then it's very serious situation. So that keeping that communication channel open, having the dialogue, being responsive, being transparent, and being proactive, like I said, some of the ways in which we could try to minimize the impact. I don't think we can get away from it, minimize the impact of mis and disinformation.
Yeah, certainly. I think that is a very great insight. As we are just coming to grips with the challenges of social media, we are also confronted with the AI. You mentioned some positive benefits of AI. There's a question around using of AI and including social media. Will it not increase the, like psychological counselor, prescriptions, all that? The gap, will it not increase the gap between policymakers and the real issue and the people? That is the question that is posed. What are there any thoughts from your side?
You mean AI, the use of AI?
Yeah, people are using AI to a great extent,
Yeah,
including, for, will it now in the whole process of evidence making or evidence presentation, like earlier we used to do,
yeah.
will it now increase the gap between policy, evidence, and the real issue? That seems to be the question.
Yeah. So, I mean, I think you have to use AI in a very well thought through and uh, in places where it could help you. There are certain, obviously, AIs can do things much quickly, faster than humans. So, if you're looking through large amounts of data and you want to pull out, the key messages, then you could use AI. But at the same time, if the human eye has to be there, and you've got to have an expert who knows the field to be able to look at it and say that this makes sense or doesn't make sense, or there's something funny going on. Similarly, you can use AI for some of the health innovations that we talked about, like reading of images. Their AI is excellent, provided it is trained well on good validated set of images. Really, it can save a lot of time, and where you don't have specialists like radiologists or pathologists, you can definitely use AI, for doing the initial reading or screening of those images. But AI is also being used to confuse people, create these deep fake videos, put out messages which are false, etc. So it has its upside and its downside, like all technology has. So when the government uses it or public health officials use it, it has to be done in a
Mhm.
thoughtful manner, and we have to study it. So I also feel that for any digital things that we're doing, new digital interventions that we're using, which is new, or we're trying to replace one of our activities with a digital intervention, we need to study it like we would study a new drug or a diagnostic. Do a randomized trial, do a proper study, and see whether it's having the benefits that we want or any unexpected risks that come up. Without that knowledge and without the evidence, I think we should not be pushing these things on a large scale.
Okay, okay. Thank you. So there's a question about you spoke about health technology assessments. I'm saying related to I'm saying it was interesting to hear about this HTSLs. Please share a bit HTSL. Yeah. Please share a bit more about this institutional mechanisms. How do the establishment of HTSLs, etc., foster evidence consideration? Because it is eventually a political decision, as mentioned earlier in the presentation. Does HTA in some way reduce the scope of evidence considered because of focus on economic valuation?
Right. No, it could be a political decision, but the political decision cannot also happen in vacuum. So there's got to be some background work that has been done. No politician will take something out of the air and announce it. I mean, it could happen, but generally what happens is you have the options, and when the time is right, then that announcement gets made. So the economic analysis is actually helpful, because as I mentioned, it's not a pure economic analysis, rupee for rupee. It looks at the burden of disease. It looks at how many lives you will save, how much disability will be averted, whether it is equitable, whether it is only reaching one group of people, what is a number of people it is likely to benefit, and so on. So introducing a new vaccine or introducing a new treatment, for example, like when the new MDR treatment had to be introduced, HTA was done, and it was because the drugs could be more expensive, right? So if you're moving to a new regimen with more expensive drugs, the policymaker will say, "Arey, I have to
Yeah.
invest so much more. Why?
Right.
Why should I invest that?" Then you have to show that 50% cure rate here, 90% cure rate there, these many more lives saved. Immediately, that additional expenditure becomes cost effective. Because when it's a question of saving lives, then if a drug is costing 500 and you're being asked to spend 1,000 rupees, but you're actually saving that many more lives at the end of it, then it works out, in a very positive way. And the minister or whoever it is can be easily convinced that this is the right thing to do.
Okay. Thank you. Another question that we have is around PABs and something around the theme of regulation. Regulatory mechanisms related questions takes good amount of time for innovations. Innovations need a lot of funding support and need to start young with regard to your take on pathogen access benefit sharing, pandemic preparedness mechanism is still under committee review under WHO for pandemic preparedness. Is it what is the status now of this that preparedness thing?
I'm not in those discussions now, so I don't know. But like
Okay.
you said, it's still under discussion. The access and benefit sharing turned out to be something which countries are not able to agree on. So hopefully in the next year we can see some progress. Obviously, the developing countries want more of benefit sharing. The countries which have all the big companies and the developed countries, they want access to data, but they don't want to agree on a benefit sharing. So this is how it's happening. It's like sort of global north versus south going on.
Okay. There is one question around the whole trust and mistrust in research that we produce. So do you think there is a sense of distrust between government departments and research institutions or slash non-profits, which also delayed this translation of research into practice? I'm saying you are also in the civil society space, you were in the government space. So what is your sense of that space?
I think it's very hard to generalize. So I would not say that there is distrust. There could be a gap in understanding or in the viewpoints that you have. But I would not classify it as a distrust. So I think both sides have to make an effort to understand the other side. If you're an NGO, then you do certain things, and you look at things from a particular perspective. If you're a government officer, you have to look from a particular perspective. If you're a researcher, academic, you will have your different mindset. So when you're sitting around the table, each one has to put oneself into the other person's shoes and try to understand where they're coming from. Then only you can try to come towards a common understanding and consensus.
Okay. Yeah. So it is not an absolute distrust. I'm saying we have to read in between the lines and see what can be done to build bridges and provide build those gaps between the civil society and the government.
Yes.
We have a
Yes.
number of young public health graduates, aspirants, and students who have are participating. So one or two questions are from them. So I would like to just provide them for your reflections. One is around health system. So can you tell a bit more about the example of redirection of funding from tertiary care to primary care? Won't it create a shortage of the tertiary care sector as well within the shortage of funds that we already have? That is one question. Okay, this is one question that you can reflect on.
I would only say that if you neglect primary health care, then your tertiary care can never keep up, because people are going to be detected late. They're going to have complications. which is going to require expensive tertiary treatment. If you strengthen primary care, you manage and control diseases at that level, you're going to reduce the number of people who are going to need those tertiary services. So, yes, you do need tertiary care, but if you have to balance, then I would say that for a few years, let's invest more in primary healthcare. That's what Thailand did. Of course, if you can keep investing in both, that's great. But if you have a limited budget, I would like to see the proportion going on primary care go up.
Okay. Yeah, unless the primary health care is robust, you can't have everything happening at the tertiary care. That I think that is the, I think, global example that we have got from all corners. Yeah. I would end with another one or two simpler questions that our young graduates be thinking like you did some years, decades back, that you would like to contribute. There are aspirations to get into research, policy, and work in the domain of health policy, think tanks, and organizations such as WHO or other bodies. So the question is, what are the perspectives and skills that could be necessary for someone to prepare for this kind of a long journey? What are your insights from your own life journey?
Yes. Well, I was always passionate about research. That was my first and only goal in life, to be a good health researcher or a medical researcher. So I think you have to be good technically at what you do. If you're a doctor, you should be a compassionate, empathetic physician who listens and understands where the patient is coming from and tries to learn from the patient. If you're not a doctor, or you're still a public health professional, again, listen to colleagues, listen to different stakeholders, and get your understanding. Be very good at what you're doing, whatever your specialty that you're choosing. I think you have to go deep into it and work for many years. Many times young people come and say, I want to join the WHO. Well, the WHO values people who have deep technical expertise and experience and who've worked in a particular sector in a particular country. I never had a goal of going to the WHO at any stage of my life. So I just found myself there. But my goal was always, where can you learn more? Can you go somewhere where you can have an exposure? It could be a community based organization, or it could be an academic center in another country. But you go there with a goal of learning something and then coming back and applying it. And I think every day one has to learn, every day one has to learn something new. That's the only way actually to be a good anything, whatever you want to be in your profession. And then finally, I think having that openness to listen, to learn, to be corrected. You can't always be right, to be humble. Science, of course, keeps on evolving. Nobody can know everything. And so I think collaboration is really the key today to success.
Thank you, Dr. Soumya, for these, I'm saying, very personalized insights from your own life. And when we were thinking of getting you to this, to this series, knowing how busy you are, we were not sure that we could make it. But thank you very much for taking time and for giving us your very precious time for us. I know how busy you are back in India. You are passionate about research. You're all the time, engaged with various kinds of policies and implementation. And these insights around both science and evidence in public health provided us such great, kind of a summary from your own life experiences, how you have straddled these worlds of policy, research, evidence, and civil society. Evidence and research need not be, posed against the policies. They can always be kind of a great, vision for enhancing them to practice the values of ethics or ethical values of equity, patient-centered. It has come out very strongly from your presentation. And we would like to thank you from the Azimtem University also for your contribution to this whole public health policy making, space, both national and the international level. And thank you for your time. Your
Thank you.
insights in addressing these questions also, some were very, I'm saying at your stage might be very simplistic questions, but you have addressed them with such kind of a, respect and with your own examples. Thank you very much. We are really fortunate to have you. And from us at Azim Premji University, the Azim Premji Foundation, and all the participants who have gathered, we have around more than 300 registrations, and many more will see this video. We'll use it as a teaching resource as well. So I'm sure we will have many more things to discuss with you at a later date. Thank you so much.
Definitely.
And
Thank
I would
you.
like to thank all the audience also for participating from different parts of the world. Thank you.
Thank you. It was a pleasure.